I'd like to introduce our special guest today. Our first guest is Dr. Lee Gross. Dr. Gross is the founder of Epiphany's Health Northport practice. He serves on the board of directors for the U.S. Medical Association, serves as the president for Docs for Patient Care Foundation, a national nonprofit organization dedicated to preserving the sanctity of the doctor-patient relationship, and has regularly led healthcare policy discussions at the state and federal levels. Additionally, Dr. Gross is appointee of the Florida Medical Association Council for Medical Economics and Practice Innovation and has served as the board of trustees for Fawcett Memorial Hospital. Dr. Gross is a six-time recipient of the Northport Sun Reader's Choice Award for Best Physician, and he earned his medical degree at Case Western Reserve University and completed his residency in family medicine at University Hospitals of Cleveland, where he was also elected the chief resident. Our next guest is Mr. Carl Schuessler, Jr. Mr. Schuessler is the co-founder and managing principal of Mitigate Partners, a risk management, cost containment, and employee benefits consulting firm that is a consortium of 25 plus employee benefits consulting and brokerage firms that have worked with healthcare leaders across the country to improve patient care, employee health resources, and financial sustainability for organizations that provide important health services. With over 30 years of experience, Mr. Schuessler has been involved in dozens of major projects, including developing his own proprietary fair cost health plan that seamlessly integrates over 20 cost containment solutions with a high-performance healthcare solution platform. Mr. Schuessler and Mitigate Partners have been nationally recognized for their work in creating localized employer-built healthcare plans in Forbes, Entrepreneur, Innovation and Tech Today, Physician Outlook Magazine, Free Market Medical Association, and Bold TV. By removing misaligned incentives, directing care based on quality and cost, and ultimately helping courageous employers fix their plans, employers are saving 15 to 30% in their healthcare spend. An accomplished speaker, Mr. Schuessler often rallies audiences with stories of how Mitigate Partners are changing Wall Street insurer-built healthcare plans by creating Main Street employer-built health plans and bending the social care, the healthcare cost curve. Thank you so much, gentlemen, for joining us. We're thrilled to have you guys. I know you have a presentation to start. And before we start the presentation, I would just like to remind our audience at this moment that we have a link that will be shared in the closing minutes for a raffle that we're going to be having at the end of our event. So we can just hang tight, and at the right time, we'll be sharing with the chat. So without further ado, we're excited to have this presentation that you guys have prepared. So whoever would like to start us off, please feel free to do so.
All right, thanks, Kalumi, and thanks to Benjamin Rush Institute for having Dr. Gross and I here. We want to get one thing out up front. We don't proclaim to have all the answers to solving the rural health problem across the country. We simply want to share a story with you guys today that has been, shared around the country of a really shining beacon of what is possible with DeSoto, for example, with what Dr. Gross and myself and Barry Murphy and the leadership of DeSoto Memorial Hospital will talk about later has achieved. So without further ado, we'll get this show on the road. Typically, I have way too many slides. Dr. Gross is already rolling his eyes, I'm sure. We got to make sure he talks because he's the smart one of the group. But really, this is about keeping the money on Main Street. It's about relocalizing care. Any of you med students out there that are in medical school right now, my father was a 40-year private practice OBGYN. It's a big deal. We have medicine is local, not national. And we have a national problem, but we have to do it locally. So this is kind of a Main Street look that we like to share. So here's a little bit about the case study we're going to share and the success in Florida. This is a hospital. It's a 49-bed hospital, and we're going to talk more about it specifically in a few minutes. But those are the leaders of the group. Vince Sika, the CEO, Lois Hilton, the HR director. There's Dr. Gross, and then Barry Murphy and myself. But this is a really great story that we want to talk about. The leadership is the key to the whole thing. And I would fail to mention, I want to make sure I mention Dan Hogan, who was a former CFO, who was very instrumental in this as well. But this leadership at this hospital, these folks are unbelievable. During Hurricane Ian, they slept at the hospital. They had the massive flooding from the Peace River that y'all probably saw on national news. They slept at the hospital for a week to keep it running. Just truly unbelievable leadership that I wish that all other hospitals across America had and could exemplify this, but they are the reason this story has happened. So thank you, Vince and Lois and Dan. So I'm going to start with a video to let you guys see it, and I hope you can hear it. I think I set it up correctly. Here it goes.
We are self-funded here at this facility and have been for 30 years. Our premiums kept going up and up and up. We're a small 49-bed hospital, and we realized that we've got to do something.
When we met DeSoto Memorial, their health plan spend was about $2.2 million. We just wrapped up the first year, and the spend was around $990,000. So they saved $1.2 million, or 54%.
It's remarkable how much you can discount the price of something if you know you're going to get paid at the time of service.
What do we eliminate? The middle. We're going direct. That's how you save. It's direct to employer contracting. We negotiated a cash knee replacement price. That hospital was 70 grand. We got it for 25.
Direct primary care, where you just pay $65 a month, and that covers all of your primary care. And sort of the bundled cash payments are two prongs of things that we can do to actually reduce the cost of health care. We also have a program that's called the Medical Advocacy Program.
They walk you through the process.
It was kind of blowing my mind when they turned around and said, well, we'll do everything for you.
Getting them to the right doctor for the right quality, lastly, the right price, and at the right time. That's what this is about.
The less we have to spend on plan, the more we're able to put back into salaries, back into maybe additional benefits or increasing benefits.
It's medical expense per employee per year. When we met them, it was almost $14,000 per employee per year. It's now right around $6,000.
Biopsy comes back, positive for cancer on the left side, and a week later, I was headed into surgery. As of today, all is well. I have gone through the process, an estimated cost of $42,000. What did I pay? Absolutely nothing.
And there was a lot of cost savings. So I actually got the bill 3 days ago, $31.76. An MRI is thousands of dollars. If something were to happen to me, or God forbid, one of my family members, it's covered.
The opportunity to take this model that DeSoto has can be replicated across the country in all these rural areas. Absolutely.
Not having to sit around that board table this year and say, okay, how much of the increase is going to go to the employees out of their pockets? I was giddy. I was excited that we did not have to do that this year.
And we deserve that. I know I do.
That video was shot by Patient Rights Advocate. They're the real leaders that helped get the hospital pricing transparency laws passed back in January 21. And their team is wonderful. And they heard about some of the work that we were all doing, and they came down and shot some videos of some of our other clients as well. So again, and Dr. Gross also has a great video that explains direct primary care that was done. This case study and story has been shared all across the country, all over the place. And since we're talking about rural medicine, it doesn't get any more rural than it was told from a deer stand outside of Macon, Georgia in November of 19, about 32 degrees. And I got done in 10 minutes. Hopefully I'll be able to do it like that this time. But anyway, we won't bore y'all with that. Now, all you med students, I know y'all don't study enough and you need more work to do. You have a lot of time off. So here's a homework assignment. You need to get this book and order this book. It's called The CEOs Who Restored the American Dream. It's the second Dave Chase book that was written, and it's a book about CEOs who have changed healthcare and changed their company, their employer, their own health plan. And so DeSoto was featured in this in November. And I'll let Dr. Gross talk more about this piece. I don't want to steal his thunder. So the vision was, we know that hospitals are critical to the health of the community. This is just stories. I'm going to fire these out of all the hospitals threatening to close. This was March of last year, 892 hospitals threatening to close. This is a state-by-state breakdown. Here's a map, a heat map. Here's another article in January 23. And then another one in February. And then, this one in November, 631 hospitals at risk of closure by state, which is why we're talking today. Again, don't think we can solve it all, but we I think have some good ideas that we can share with you. So the biggest thing that I think is important is any of you med students who are going to go out and work somewhere, you're going to go to a metropolitan area, you're going to go to a rural area. So people move for three reasons: jobs, education, and healthcare. If healthcare dries up, the town dries up. Look, do your research, look across the country. It's a big deal. So that's what we're here to talk about. Hospitals are critical to the health community. They have local access to healthcare. Large employer in their own right. They're usually the largest employer in these rural areas. And they have to attract new employers to the community, so we need to keep their doors open. And the ultimate goal is to, again, protect the integrity of the employer health plan. These are employers who have health insurance they offer their people, but keep the money local while supporting local providers like DeSoto Memorial Hospital. And it ultimately benefits the employees of these companies that are centered in a town like Arcadia, Florida. The obstacles, the current system, as we like to say, favors the insurance cartel at the expense of everybody. Insurance companies and the pharmacy benefit managers, you ever heard of Optum, Express Scripts, CVS Caremark? Those are the pharmacy benefit managers, otherwise known as program bilking millions. They're in control. They negotiate contracts for the hospital for their own benefit, not for the hospital's benefit, for their benefit. They control plan offerings for the employers. They impede direct communications in the community. The physicians especially migrate to where the dollars are. That's why it's hard to attract doctors to rural areas today. Lack of pricing and quality transparency in the market. And again, the consumers don't know what things cost. And again, the plans that are built for consumers or employers are not built correctly, and they don't reward them for making good decisions. So here's an example of the biggest issues in healthcare, really across the country. What if bought groceries the way we buy healthcare?
There are no prices on anything here.
Oh, believe me, some of it's pretty spendy. Whoa, that's really gone up.
Stop. I don't need both, just one or the other. It depends on the price.
Oh, that's called shopping. We don't do that here. Thank you for coming in. Your bill? Your version will be mailed to you in 30 days. Good luck trying to make some sense of it.
So I'm sure some of you are laughing out there. It's really not funny. Healthcare is the only thing in America we don't shop for. We don't know the price for 30 days. And that's not how it has to be. That's what DeSoto Memorial's been able to do in Arcadia. It doesn't have to be that way. So here's a great example. This is a colonoscopy billed as a multiple of Medicare. The orange represents a multiple of Medicare. So DeSoto may be billed out at 6.3 times Medicare. Sarasota Memorial Hospital, 8.6. Lee Memorial at 8.7. Tampa General, on and on. And then you look at Fawcett Memorial, 21 times Medicare. So what does that mean? What does an employee of a company that is in, say, Arcadia, Florida, look to spend? What is it going to cost them? Colonoscopy at DeSoto is $2,940. But if they pick the wrong hospital, it could be upwards of $21,000. And those are things that DeSoto has really just broken the walls down so that people can find this out and know that. And that's important. And many of these rural hospitals give great care too, and they usually can do it a lot less costly than a major hospital system. So where do the Central Florida citizens go for health care? This is a major joint replacement. That's what Lakeland Regional charges. Tampa General charges $106. Sarasota Memorial charges $82. Fawcett charges $157,000. Grab your wallet. Bayfront charges almost $117,000. Lee Memorial charges $80,000. And then Arcadia, you look at DeSoto, there it is, $18,550, a five-star hospital. There's only about 16 five-star hospitals in Florida. That's what they charge. So it's a big difference. But for all you med students, the employees that work at these companies, they don't know this, and they have no way to know it. And that's why you have to do the plans right and take advantage of these local hospitals to work with you and design programs for you to help benefit you. This is something Dr. Gross shared me years ago, but that's a real difficult challenge. I showed this to my dad and he laughed, as I told you, he was a private practice OBGYN. How can you help the patient when you haven't looked through a third party? So you got to eliminate the middles. So the new way forward is community built healthcare. It should be built for your community. It should be Arcadia-built healthcare, not insurer-built healthcare, and get rid of the insurance companies and the network interference. You don't need it. Direct contracting works well. Thanks to Dr. Gross, DeSoto Memorial was able to achieve some great relationships outside of their community for certain specialties they needed. And we were able to do direct contracting, no intermediaries. It's based on fair and reasonable reimbursements, neighbors working with neighbors for the benefit of all. Back to the Marcus Welby MD days, the way it was. Any of you youngsters out there, Google Marcus Welby if you don't know who it is. That's the way it used to work. And that's how it can go back. Relocalize it, bring it back, community owned. Ultimate benefit of the employees. And again, the employer built health plan. This is the DeSoto Memorial built health plan. We use granular data that we all analyze together, including Dr. Gross, to actively manage their health spending patterns. We were able to steer to the local hospitals and pharmacies, again, and offer affiliate hospitals, tertiary hospitals for things like cardiac care that DeSoto didn't do, obstetrics. And again, with Dr. Gross's team and Dr. Hubman there as well, and Dr. Crouch, you've got the resources in place to impact the chronic conditions. And again, you don't necessarily have to have networks. It just has to be a fair and reasonable reimbursement. Everyone needs to win. And you got to engage the employees of these companies. And that's one of the great things that Dr. Gross and his team does such a good job of. So the bonus for the community is, we now, DeSoto has their own pharmacy inside their hospital, and they can pass on their acquisition cost to other local employers, which again, drugs is a big problem in America, folks. Y'all know that. I mean, most people can't afford their meds. Most people don't have $500 in their checking account. How are they going to take the medication over deciding what they're going to put on the table at dinner? That's a problem. So there are different strategies. Well, I'm not going to go into all the details, but these are some of the different strategies that can help. And again, you've got clinical support as well. Since they're a hospital, you have a lot of help for the employee and the employers. Benefits of the hospital, most of it can't, if it can't be done there, there's other opportunities for people to go to. Also, we let the employees use DeSoto Memorial Hospital with no deductibles and no out-of-pocket cost. So DeSoto's not chasing down people for their deductibles and their co-insurance money. Hospitals only collect about 7% of that money. That's kind of a problem. We remove that barrier. Quick payment. They're paid very quickly for their services. And then again, this is one of Dr. Gross's favorites. We have been able to eliminate pre-approval, prior auth, pre-certification, things you've heard about with a lot less red tape. And everybody's happy with that. And again, those chronic conditions, those people like that are the ones we really need to watch and take care of. It positions DeSoto in a significant place in the community to really help all the employers that surround the area. So the benefits of the city and the county: lower trends in healthcare spending, health plan dollars that can be spent elsewhere. By saving money, you can put more money back in your community to the local merchants instead of having half your paycheck go out for health insurance. And again, all transparent. And this is number, for you med students, this is usually number 1, 2, or 3 on a company's profit and loss statement. It's kind of a big budgetable item. And again, it gives them more transparency and control. And again, because of the coordination with Dr. Gross, Dr. Hubman, and Dr. Crouch, we are able to all work together, and we have different solutions in the DeSoto Health Plan that can benefit the member and have them adhere to medications, take care of themselves, be happier and more productive, and at the same time, save everyone a lot of money. And again, my favorite saying forever has always been, keep the dollars on Main Street versus Wall Street. When you go to a Walgreens, a CVS, or a Rite Aid, you're putting money in Wall Street's pocket, folks. Keep the money local. It helps your local economy. That's what this is about, relocalizing the care. And then it's a nice tool to attract new employers to community when they see what other employers are doing. No barriers to care with no deductibles. It can be quite substantial boom for that city to grow. Benefits to employees, again, they have access to health care. They don't have to worry about going out of network anymore. And again, friendlier plan designs allow them to have a much better coverage without being prohibited from using the health plan for fear of what it costs. You'll see a video later that talks about that. And again, they finally can know what it costs We share those examples with you. The employees have those tools available to them to know what this costs. And they've got guidance from Dr. Gross's team, nurse navigators, et cetera, that really help them with that. So what we propose is the city, county, and DeSoto take a lead in establishing a health plan partnership. That can happen across America, folks. Hospital's critical. It's kind of the nucleus, but it can happen in these rural communities. That's what we're trying to do here. And our goal is to invite all the other employers, the city, the county, the school district, all the other local employers to this. We are in the middle of doing that. We've been derailed by COVID twice and Hurricane Ian in September. Massive flooding down there. Like I said, it was a national news story. So we're working on it. Neighborhood health care is what this is all about, folks. And by eliminating these communication barriers that exist in the health insurance world today, we can break those barriers to care and allow the rural hospitals, the doctors like Dr. Gross, Dr. Krause, Dr. Hubman, and the pharmacists, local pharmacists, the pharmacists at the hospital to more effectively serve the community. So in wrapping up, this is the case study you heard a little bit about in the video. This is it's just one of our favorite stories. I mean, we love this entire story. It's a 5-star hospital, folks. Again, there's only like 16, I believe, in Florida. They're a 5-star hospital. They give great care. The challenges, they're the 4th poorest county in Florida. They had the 2nd lowest family median income. They lost obstetrics in February of 18. Members have to drive an hour for deliveries. That's a big deal, guys. And I hope we'll talk about this when we do the Q&A, but maternity care is a big deal. And they lost obstetrics in February of 18. Members got to drive an hour. Foreign medical spend was 79% the last 4 years. That means that 79% of the money DeSoto Memorial spent on their health plan was going to other hospitals outside of their community. That's a big deal. That means they're paying money to other hospitals and not their own. That's what their spend was. They spent that much on their health insurance. The results, they saved $150,000, 58% in their stop loss premiums. They weaponized their plan design. They implemented DPC with Epiphany Health, Dr. Gross and team. Hired their first full-time surgeon in county history, folks. That's significant. And then their foreign medical spend went to 62% the first year, and 3 years later, it's at 45%. So people that work at DeSoto Memorial are getting their care at DeSoto Memorial. Oftentimes, people don't want to get care in the hospital they work with, maybe because they don't want someone to see them naked. I don't know. It's all different for everybody. But because they have no barriers to care there, they're incentivized to use their hospital. And that was their spend. And then they had a rate decrease, the second ever in the history of the stop loss insurance company. And that was their savings, 1.2 million, 54%. So moving forward, you know, if we pull this off and can get the community involved all across America with the hospitals, we can eat like kings. And I'm going to turn it over to Dr. Gross. So he'll talk to you about the story of what he did. Take it away, Dr. Gross. I'll stop the share.
Thanks again, Carl. And thanks, BRI, for the opportunity to present this. So as Carl had mentioned, the name of my practice is Epiphany Health. And Epiphany is a very strange name for a healthcare company. But in fact, we did have an epiphany. And our epiphany was, you know, why are we insuring primary care? Why are we inserting so many obstacles and so many barriers between a doctor and a patient, and then complaining because it's expensive, it's cumbersome, and it's impersonal, and it's hard to navigate? So in 2010, we had a small business that approached us that said, why don't we just contract with you directly to take care of our employees, and we'll all save money? And so it gave us the opportunity to redesign what was a fully insured traditional fee-for-service practice here in Southwest Florida. And so we drew up a business plan and effectively created what turned out to be one of the first direct primary care practices in the country. We created a subscription-based primary care program. And once we flipped the switch and turned this thing on, something interesting happened is we suddenly saw uninsured patients come to our little practice from all across the state of Florida. We would have patients driving from Miami, from Orlando, from Naples. They drive 2-3 hours away to get care through us because they could afford what it was we were doing. So to give you an idea of what that is, right now it's $85 a month for an adult, $30 a month for one child, and $15 a month for each additional child. And after that, we don't charge anything for the services in our office, and we bill nothing to a third-party insurer. So again, we suddenly had an issue where we had a huge uninsured population that were traveling great distances. So now we had to determine what services we could get outside of our offices. We needed affordable labs, affordable imaging services, affordable physical therapy. And so we built a cash-based network of services. And it turned out in almost every situation, our patients that paid cash paid less than our patients that were paying co-pays using insurance. And if it applied towards their deductibles, the savings were substantially different. So now, fast forward a few years into this program, and we now started to see these patients that now needed actual surgical services within a hospital. And as Carl pointed out, in most hospitals around the area where I practice, the charges for these services are exorbitant. And so that's how we ended up creating a relationship with DeSoto Memorial Hospital, because if a hospital like Fawcett Hospital decides that they're going to sell a knee surgery for $22,500, when they're used to selling it for $125,000, they're going to lose a lot of money. But a hospital like DeSoto that's not full, and they can add these as additional revenue to their not full OR schedules. This is just additional extra money that the hospital can sort of add to their margins, and it helps them immensely. So we are now sending uninsured patients from all over the state of Florida to have procedures done at DeSoto Memorial Hospital. We're sending them for colonoscopies, hip replacements, knee replacements, hernia surgeries. We're sending them with kidney stones and all sorts of things, all on a cash-based arrangement. And so after years of doing this, it became obvious that what we could do really should be done with their employee health plan. The savings were so substantial, and that's how we ended up getting hooked in with Carl. And we sat down together, and Carl put together a brilliant program that has become the hospital's premier employee health plan. This is a picture here of Carl making a presentation to the employees of DeSoto Memorial Hospital at the rollout. We had a series of meetings all day long with all the employees, and we joined that. But I want to point out a couple of things here, and hopefully you can see my pointer here. But the price for the employees in the direct primary care portion of this, and let me step back a bit. I just want to remind you that the hospital was already self-insured. They were self-insured through a commercial TPA, a commercial pharmacy benefits manager, and Carl went through and they basically took out all the middlemen from this and contracted direct with everybody. So they used independent TPAs and independent stop-loss carriers and so forth. So that's the first thing. The second thing is they added the direct primary care as an option for the employees. They didn't tell them they had to do it, but they gave them the option. They could stick with their existing physicians. They could go to their primaries for standard copays and deductibles. But if they chose the direct primary care portion of it, the hospital would pay the direct primary care membership for them, and then would also provide the insurance to cover services that are not being able to provide inside our DPC offices. What I want to point out here is that for the direct primary care portion of this, the employee is only paying $40 per pay period. So that's $80 a month essentially for the direct primary care, which I already told you is $85 a month. And that also includes the insurance for an individual. So what we have is the opportunity to have the data before Carl and his team took over. So, and then the data afterwards, and then we also have it divided out into the direct primary care versus the non-direct primary care. So we have a before and after, and then we also have a built-in control group within the population to determine what the outcomes are for these populations. So what I want to focus on really is this section here, which is the outpatient costs. And this gray bar here represents the total health plan spend per member per month. I'm sorry, this is the national benchmark for a population of this size. This green bar is what the plan spent in 2019, which was the first year implemented. And in 2020, the second year the plan was implemented. So you can see that the total plan outperformed the benchmark immediately right out of the gate. So we already saved money. And just a reminder, we saved money by eliminating copays, eliminating deductibles. We eliminated barriers. So there were not $10,000 copays. We didn't have to get prior authorizations and step edits for every single service like all the other plans do. So, but if you break it down into the direct primary care versus the non-direct primary care, you can actually see something starting to develop here. So again, focused in this outpatient section here, the national benchmark for this type of population is here on this gray bar. And you can see that in 2019, the non-DPC plan saved money, but in 2020, they were already back up to the national benchmarks. Still, again, performing well compared to the national benchmarks. But if you look at the actual direct primary care side of it, you can see that that's largely what was driving the cost savings within this population. So, and here's your benchmark, here's year one, here's year two. We actually got cheaper as we went along. And if you look actually into year three, looking a little different here, again, gray bars are the benchmarks here, 2020, 2021, 2020 on the left, 2021 on the right. The blue bar is the spend on the direct primary care side. The orange bar is the non-direct primary care. So you can actually see massive savings on the total spend in the direct primary care side of things. So if you extrapolate out the full 3 years, what you actually see is a 38% savings in the direct primary care side of the practice. So we actually saved money with no copays, no deductibles, essentially free primary care services. The total out-of-pocket spend by the patients was reduced by 30%. So copays, coinsurance, deductibles were eliminated. The nice thing about direct primary care is because my office time is not spent fighting with insurance companies, dealing with authorizations and step edits, and because Carl set it up so that everything that we refer to is automatically covered, it frees us up to do more within the office. So less referrals to specialists, more availability in the office. And so we actually reduced emergency room referrals by 40% in the direct primary care side. We had a 30% reduction in the amount of money that was spent in a specialist's office. And interestingly, when you say, okay, but you prepaid for the primary care, therefore you probably spent more on the primary care. But when you actually look down here, the primary care was actually 20% cheaper in the direct primary care side. So it turns out that when you have a fee for service primary care office, they're very efficient at extracting money per patient visit. That's what they do. Every level 3 visit should become a level 4 visit, should become a level 5 visit, should result in nebulizer treatments and so forth to essentially run up the bills. We have no need to do that in the direct primary care side. So we actually don't have to try to extract money from the plan or from the patient. And we don't have to look at the patient's insurance as an ATM machine to fund our practices. So the logical question is then, well, you obviously, just because you were so cheap, you must have had a healthier population. But in fact, we had 21% more chronic disease in the direct primary care group. If you look at the blue bars here compared to the green bars, the green is how much chronic disease you would expect in a particular population. The blue bars are what we actually had in our population. And you can see in almost every instance, we had more disease within our population, including a triple of the amount of coronary disease, and we even had more cancer in the population. So these are sicker patients that were managed for less money. And I want to focus on two things here, because if you look at the national benchmark for managing diabetes, the national benchmark is $4 per member per month, and we did it for 72 cents. So an 82% reduction in management of one of the most common conditions that you see in the country. So you ask, well, why would that be that you can do it for so much less? And I think one of the important things is that when you're on that treadmill in a fee-for-service practice and you're spending 5 minutes of your 7-minute office time trying to make sure you click the boxes to make sure that you get paid for your services, then it takes 3 minutes to write a prescription that costs $600 a month, but it takes 30 minutes to not write that prescription. It takes 30 minutes to teach people what they need to do to not need these extra medications and maybe even get them off the medications. So we actually were able to save 82% on the management of diabetes. Down here in the dermatology part, we don't usually refer out our dermatology or routine stuff. So we do biopsies in our practice and we can take off minor skin cancers. So what might cost $2,000 in a dermatology office, we can do for $35 in our office just by paying the pathologist fee for our services. So we were able to save about 85% on our dermatologic services. To Carl's point about the domestic spend versus foreign spend. So again, this hospital is the insurance company. So the hospital provides most of the services that can be done for the employees. So it to their advantage to keep those services within the hospital. So the way Carl designed the plan and the way that the team designed the plan was, if services were done in the hospital itself, it was free to them. Again, no copays, no deductibles, free MRIs, free CAT scans, free surgeries. And so you can see here, before we started on the non-direct primary care side, we had about a 50-50 spend versus the patients in the direct primary care versus, I'm sorry, foreign versus domestic. I'm sorry, I'm getting confused here, but so again, this is before we started. You can see that there was about a 50-50 spend, how much was spent locally versus away. And now on the direct primary care side, 85 cents of every dollar are spent at the hospital. So we were actually able to get the patients the care they needed by managing them through the hospital itself. And so of the money that was spent, 85 cents of that money was spent from the hospital's right pocket to the hospital's left pocket. So we saw, once we launched this, we saw almost a 30% year-over-year growth. Again, the direct primary care was optional, but word of mouth, people started to talk to their friends, and we started to grow. And so we can have seen 30% year-over-year growth in the DPC uptake by the employees. We had an initial 20% reduction in the employee premiums right off the bat. And the thing that I love, and you saw Lois in that video saying, you know, we had to sit down in the conference room and say, how much of this money is passed down to the employees? How much do we have to pass along because of the increases? We are in year number 4, and that $40 that I showed you per pay period, what we charged at the launch, is exactly what they're paying today. We have not increased the premiums to the employees 1 penny since this plan launched in almost 4 years. Carl already mentioned the stop loss premium. Because of the way that this plan was designed, we were able to have a successful practice that was able to allow us to bring in a full-time physician to manage our DeSoto location with DeSoto Memorial. So we brought in, this is Dr. Hubman. So it started off with me and Dr. Crouch, now has a full-time presence out there. So it allowed us to expand resources to this community. And as Carl said, you know, the first year before we launched this, it was about $2 million in spend. It dropped down immediately and then started to go up. So we did see about a $1.2 million savings. The difference between my numbers and Carl's numbers are whether it was calendar year or fiscal year, but they're the same numbers. And if you look to what Medicare does when they try to build this mousetrap, they created these rural accountable care organizations, these very complex mousetraps. And in 5 years of rolling out ACOs, they lost money, and they finally actually generated some savings in 2019. And they saw $64 per beneficiary savings. And on our first year, we were able to implement $2,420 per beneficiary saving. So it's not even a fair fight, unfortunately, with this. And so many people would say, okay, but you know, obviously, if you're making people get the care done at the hospital and maybe they don't want to go there, you're cutting services, you're getting rid of networks, then people definitely have to be very unhappy you've given them a stripped down plan. And I just want Hannah to finish telling her story here, and hopefully you can hear this.
Well, the benefits that we have here at the hospital are more so focused on the employees. The latter part of August, I had a concern regarding my neck, and I went in to see my primary care, listened to my concerns, and he recommended certain protocols. It was my choice of what I wanted to do. You would think with the specialist, the appointments are so far out. Within maybe 3 weeks from seeing my primary care, having my test done, getting my results, finding out that I needed to have a biopsy done. Biopsy comes back positive for cancer on the left side, and a week later, I was headed into surgery. As of today, all is well. I have gone through the process, an estimated cost of $42,000. What did I pay? Absolutely nothing. So before, I was paying all that money on my premium, and I never used the plan because I was reluctant. Because if I have this copay, I'm going to have this deductible. We don't have those issues. Every concern I've had since day one of this plan, I have addressed and have taken care of this year. And I've paid absolutely nothing out of pocket. And we deserve that. I know I do.
And I think with that, why don't we go ahead and open it up to some Q&A.
After such a good presentation and hearing Hannah's story, I want to get a plan like that for me. So
come on down.
we have a few pre-planned questions, and the audience is welcome to share a few questions. There's going to be screened, and I will read for us. I guess the first question that I have maybe is just clarifying what you guys shared. So how does this plan work? Because it almost feels like something that's too good to be true, but then we hear stories and we see numbers like, wait, so this does work. But who can benefit from such plans? I guess if I can rephrase the question is, can I go and get a plan like that for me, or do I have to be participating with a hospital who subscribed for that plan and I'm an employee of the hospital and then I get that plan? Versus for me and my family, I want to get those savings. How can I do that?
Dr. Gross, you gonna take that, or you want me to?
No, that's in your wheelhouse.
Did that make sense? Or I feel like maybe did I make things more confusing than they have to be?
No, you're good, Clemmy. I don't know that I have a wheelhouse, but I will attempt to try. The goal of what we've done here is to take the plan that was created at DeSoto and go to other employers in the community. Normally the largest employers in these rural areas are the city, the county, the school, obviously the hospital. You go and replicate the plan that DeSoto has at those employers. They can build their same plan, an employer built plan for them, but they have to leave the insurer built plan, get away from an insurance company to build something like this where it can work this way. You can't go find I'm gonna pick on one, a Blue or United plan with no deductible. They don't really exist anymore. And if they do, the employer will go bankrupt trying to offer it. So by building it with cost containment solutions, Dr. Gross, DPC is a foundation part, if you want to call it a home, the very foundation of a house. That great primary care has been significant to this. We have other solutions in there, but it's the primary care and they're the quarterback that has allowed it. But you can replicate it within the community is how you would do that. Does that answer your question, or I just make it a lot more confusing?
No, it does. It does. So we have a DPC practice who is working alongside a hospital. We're going to provide services and everyone's saving money.
Yeah, I think the bigger thing, Clemmy, too, is I don't think people are understanding. Folks, this is a hospital.
Yeah.
They have doctors, and they hired Epiphany Health, Dr. Gross, to help manage their population. Dr. Gross, you ought to kind of tell that story, how that happened. But I think that's a bigger part here because hospitals have internists. Many of them do,
Yeah. And we just signed a 3-year contract extension with them, by the way. So obviously very happy with the services.
I have a few questions here from the audience. Question number 1, how do you keep track of the avoided ER visits handled by the DPC doctors? Do you report this to the client annually or quarterly? Thanks and keep up the great work.
I'll take this one. So there are certainly some practices out there, some DPC practices that actually do record a preventable ER visit. They'll track that sort of thing. The data that were reported here truly was on the plan spend, on how much they spent in the emergency room. So on the DPC side versus the non-DPC side, you could actually look at the dollars that were spent on emergency room care, and that's where we saw that drastic reduction in ER total spend. We didn't track the actual total number of visits in the ER, but the total spend is what we tracked. And again, and that was per member per month, so it wasn't just the total plan spend.
I'm going to add a secondary question to this one. We're talking about preventable ER visits. How do we tackle that with a DPC model such as what you have, Dr. Gross? Is it the time that you have available, whether through education or just like, hey, we have the time we can do this here versus sending you to the hospital to have the same procedure done at the hospital at an ER bed that can be done at a clinic and you're here? Is that what is it a time frame in which physicians are fighting for 7-10 minutes and when they have to document for 8 minutes? I don't have time to help you right now. You have to go to the ER versus I have the time. You already paid me. And we have the time. I'm going to save you the money and time now.
Yeah, absolutely. And so it is about the time. It's about the how you set up your practice. So if I'm a standard fee for service practice, if I walk into my office in the morning and I have open slots, that's lost money. So my, as a fee-for-service doctor, my schedule is filled before I even walk in the day, and anybody that calls with a problem either gets double or triple booked onto my schedule. You have 3 patients, 5 patients in the same time slot. You get referred to maybe a physician assistant or a nurse practitioner who doesn't really necessarily know as much about your care or your history. Whereas me, when I walk into my office, I have 2 hours out of my day already open for same-day emergency visits. Because I'm being paid to be available. So if you call me in the morning, you can usually be seen within the hour. If you call me in the afternoon, you can be seen within the hour. And so it's extremely rare that we have to refer patients to the emergency room because we're too busy to do so. And because our schedules are designed in such a way, we can avoid some hospital admissions because I can see somebody back 2, 3, 4, 5 days in a row and give them outpatient care with close observation because I know I can see them back and I know I can have the continuity, as opposed to if I had a full schedule, I know I couldn't get him back in and give them daily antibiotic doses. And so I'd send to the emergency room to be admitted to the hospital. So it really has everything to do with the practice approach and how things are designed.
That's a great answer. We just got another question here. How do hospitals break off from existing contracts with insurance companies, insurance firms to begin partnering with DPC doctors, emulating the model that Dr. Gross and Dr. Schuessler presented? Wouldn't there be some sort of legal pushback because the existing established systems?
They call me Dr. Schuessler. I like that. My dad would like that a lot, but I didn't go to medical school, just so everybody knows. Go ahead, Dr. Gross. I can piggyback after you go.
No, I mean, it's obviously you have to look at your I think the question is, how do you break away when you're already you're already locked into the system? Obviously, you have to understand the contracts that you've signed. I mean, even as a DPC doctor, I was threatened by commercial insurance companies when I tried to cancel my insurance if it wasn't done at the right time, if you didn't use the right protocols. But I think Carl probably could better answer, how you actually structure it. But you got to be careful, and there are lots of legal issues surrounding how this has to be done.
I'll give a quick story. Vince Sika, the CEO of DeSoto Memorial Hospital, went on an appointment, went to with Barry Murphy, who works with me on this plan. And we went to an adjacent school district to DeSoto County, where they are. And I never forget, somebody goes, well, Mr. Sika, if we came in there and wanted to pay cash, how do we do that? And by their contracts, everything that I understand about it is if you come in and present your insurance card, then the hospital really can't give you a cash price. That's part of the contract they sign. And as I like to say, if that isn't a cartel, I don't know what is. I mean, come on. So they do that. And then Vince said, if you come in and want to pay cash, we can do that straight up, no problem. But if you show that insurance card, they got to walk that line.
Wow. I guess maybe this question would be more guided towards Dr. Gross. But what can medical students and residents do to prepare themselves in order to serve their community in a way similar to what you guys are presenting, whether it's through the DPC practice versus, I guess, it makes sense on my mind when I see a primary care physician desiring and planning to open a DPC practice. But what happens if I'm a surgeon? Or what happens if I have some sort of like a different specialty that's not primary care to replicate a similar model?
Yeah, so I think it's already being replicated in all 50 states in multiple different specialties. So what started off as a handful of direct primary care practices in 2010 are now probably 2,000 practices, if not more, in all 50 states, with special legislation to protect them in 37 of those states, and a few of them are advancing legislation presently. Obviously, not all specialties are amenable to subscription-based services. I mean, just how many times do you want your gallbladder out? You don't need a monthly subscription for that, right? But transparent cash prices are absolutely something that can be done in those situations. And specialists can, seek out the Carl Schuesslers of the world and the DeSoto hospitals of the world and offer them reasonable, transparent cash prices on their services. It's something that's required by law right now, but most people are not complying with that law. The penalties are so low that their compliance rate is probably not even 10%. hospitals that are disclosing their actual costs for these services. As far as learning about this, I mean, attending, conferences like BRI and learning what type of innovation is being done in the sort of transparent market space is important. And then many organizations put on free conferences or low-cost conferences around the country to teach physicians how to run these practices. As you know, most med students nowadays are not taught business in med school. I was taught business in med school. We had an extensive business training, but that's not taught anymore. So you have to seek that knowledge out yourself. And there are there's still DPC conferences, but most of them bring in specialty care at this point.
Okay. Yeah, I wish I had some of these classes at my school. and I just wish they were replicated in all the schools in our country. I think that's so important. It's just unfortunate that it's taken for granted we don't have it anymore.
But I want to say something that's important, and it's not related to that last question, but why this is specifically geared towards rural healthcare, and it's appropriate during this conversation. So our practice in Arcadia right now probably has 400 DPC patients in it. That is a fiscally viable practice with 400 patients in it. If I was a standard fee-for-service practice with 400 patients, I'd be out of business. It's not sustainable in a rural setting, and so a lot of these fee-for-service practices can't make it unless they're subsidized either through federal subsidies or charitable subsidies. This is not charity for us. This is a for-profit operation. And so if you look at states like Alaska or Montana, where everything's rural, then this is absolutely an essential tool in that tool belt to survive or make rural healthcare possible. And using the price transparency of the cash-based referral system that allows self-funded plans to then support these rural hospitals, let routine services and routine care be done in these centers and allow the complex stuff to be done in the tertiary care centers. That definitely drives critically important elective volume to these facilities to keep them afloat.
Yeah, I also want to say something that Dr. Gross made the great comparison for. Dr. Gross, you're the expert, but most DPC practices will try to have 400 to 600 patients, and they get over that, they bring in another doctor. The normal fee for service practice in this country, internist wise, is, if they're an internist or family member, they got 2,500 to 3,000 patients. That's why they refer out to specialists all the time. And we could tell a story about another client of ours that Dr. Gross and I work with, but we won't have time today, when Dr. Gross was a fee-for-service doctor. But that's what happens. And that's really the big magic of direct primary care, is you're in a direct relationship with the doctor, not through an insurance company.
Yeah. We just got 2 more questions here. It seems an interesting one. So my small town in Texas lost its hospital, but not its hospital district in 2018. And we now only have 2 NPCs, no MDs or DOs, with a client base of about 10,000. The local population is 70% Medicare and Medicaid. Is such plan feasible for such a town?
Well, I think that's one of the reasons why it's so critically important to not lose these hospitals, because once you lose these hospitals, it's hard to get them back. I mean, to try to start up a hospital from scratch with that demographic, I think would be cost prohibitive. But that's not in my wheelhouse to be able to truly answer that question. I know if there are no physicians in that community, I think in Texas, I'm not certain if the nurse practitioners can practice independent of physician oversight. That's a complicated question all by itself. Physician hospitals are still banned from being built in the United States. So by the Affordable Care Act, it's illegal for physicians to own a hospital unless they don't bill Medicare. So if it's cash-based, you started off as a surgery center or freestanding emergency room that doesn't accept Medicare, then you probably might be able to do it. Be hard to staff that full time with that demographic, but that's why it's critical to not let these things fall in the first place.
Whoever that was that asked the question, they're an anonymous attendee. Reach out and give us a holler. Dr. Gross, it says there they didn't lose the hospital district, they lost the hospital, but your point, I guess, would mean they'd have to start another hospital. But whoever that is, I think our information's out there. Sure, feel free to reach out, and I see Dr. Cavell. I know Dr. Cavell up. He's in Pennsylvania. I guess he's next.
Let me scan here for any more questions.
I think we answered Arvin's question. Good to see you, Arvin.
Yeah.
So let me see if I understand this question. So many clients are used to traditional way of insuring their workforce, and in the modern age, there are better solutions. Can you help everyone understand that this is not any more risky than their insurance build plan? People get stuck on networks and their own docs, but please put people at ease that this is a better solution.
Dr. Gross, you want to take it first and I'll go behind you?
Yeah, I mean, I think when you're fully insured, if you have your best year, you don't save any money. The insurance company just happens to have a good year on your behalf. When you're self-insured, if you have a good year, you keep the savings. And so there is no savings in a fully insured model. So you're having your worst year every single year when you're fully insured. There obviously are some risks in self-funding, which are mitigated through, special programs and stop losses and so forth, and plan design. But I think, Carl again and his team have built a great mousetrap for that.
Yeah, I like that. Great answer, Dr. Gross. I think the biggest difference is, if you're in that insurer built plan, or whoever asked the question, or if you got clients or whatever, if it's you, how's that working out for you? You're getting increases every year. Your benefits are getting worse every year. You're giving more barriers to care, and then the employer is asking the employees to shoulder more of the burden of the cost of the plan. It doesn't work. It's not sustainable. So with a self-funded plan, if you do a self-funded plan via an insurance company, it's still an insurer-built plan. DeSoto had an insurer-built plan when Dr. Gross introduced us and we all met. They don't have that anymore. So just because you're self-funded with an insurance company driving the ship, that won't do a whole lot. But doing an independent TPA, unbundling and deconstructing the whole program like we did can work, and it has a lot of solutions in it to control your cost and protect you. Groups as small as 5 employees are doing self-insuring right now. It's absolutely possible to take what DeSoto did and replicate it across the country.
That's awesome. And I think it would be a good time to wrap it up with those good news that it's possible. And I'd like to give you both, gentlemen, again, thank you so much for coming, an opportunity to have any closing remarks. We'll be sharing the link for our raffle in a few minutes while you guys are sharing our closing remarks.
Go ahead, Dr. Gross.
I guess I will just say that while I and Carl and I may be the sort of faces of this, there are so many people that go in behind the scenes to make this program a success, between the administration and my team here at Epiphany Health and Carl's team and his Mitigate partners. I mean, this is an entire community that's making this work, and the employees through DeSoto Memorial Hospital are just an amazing group of folks, and we're honored to continue our relationship and keep working with them, and we're looking forward to using what we've learned here. Proof of concept that you save 50% on health plan spend. If Medicare saved 5% on health plan spend tomorrow, it would be front page of the New York Times. We've sustained that for 4 years, and we're still going. So I appreciate the efforts and the letting us tell the story.
I want to, on behalf of Dr. Gross and I know we already thanked, but I want to thank the Benjamin Rush Institute and Richard Walker's leadership and everything that you guys do, all about preserving the patient-doctor relationship. And for all you med students or any folks out there considering medicine, the patient is a target for profit right now, sitting way out here in the outer sphere, needs to be put back in the center with the doctor. That's how this worked. That's how it always worked before all the middlemen got involved. So I want to thank y'all for all you're doing and the scholarship program you've created. And the doctors are personally near and dear to my heart because of my father, and I grew up around medicine my whole life. I don't know a lot about medicine, but I did grow up around it, and I've heard the talk. I grew up around a lot of doctors. So I thank y'all for the service and what you provide, because I think the physician is arguably the most critical person in the system, and with partnering with good hospitals like DeSoto Memorial makes it possible. And the DeSoto Memorial leadership, you can't say enough about it. They're the reason this happened. Vince, Lois, Dan, they're unbelievable. And what they do in their community and how they've risen. I think Dr. Gross, you said when we worked with them, they were a 3-star hospital, maybe they became a 5-star now.
They didn't even have enough volume to have a star at all. Yeah.
And some of Dr. Gross's friends and other DPC doctors have sent patients there for surgeries. Is like a tour, like a centers of excellence, a medical tourism type destination. And that Dr. Gross has been behind numbers of those. That knee replacement we shared was the one Dr. Gross did, $18,550. That was a program he put together.
Wow. Thank you so much, gentlemen. Thank you, Dr. Gross and Mr. Schuessler, for sharing and all the encouragement that you guys bring to the table. And I'm sure that, well, I'm one encouraged medical student. I'm sure there's many more that's watching with us live right now, and that will be sharing with our YouTube channels and everything that we can encourage many more. So with that, I wish you guys a great day. There, you guys have a blessed day.